Hey, Ellis, how are
Hey, good morning. Can you hear me?
you? Like my virtual background?
Oh, very nice.
I'm a team player here.
Yeah, they designed that logo while I was at Mount Sinai. It was a big deal. They put it on everything.
Nice. I'm sure somebody was paid a handsome sum to come up with it.
Yeah, exactly.
I enjoy using that term, a handsome sum. Alice, are you still having EP conference in Montefiore?
Yeah, Friday was my last day of fellowship, so I'm done. But yeah,
Wow.
we're still doing it.
Are you in Texas already?
No, not yet. I'm moving on Thursday, so just packing up the apartment this week.
Exciting. We have a native Texas person on the line, Grace Kong.
Oh, hi, Grace.
Oh, hi.
Awesome. Are you from Houston, Grace?
I am. I went to Baylor for med school, actually.
Oh, amazing. Oh, well, offline, I'll have to get your recommendations.
Yeah. Good morning, Dr. Bass.
Hey, David, how are you? Welcome.
I'm good. How are you?
I'm well, thank you. Okay, so I'm very excited because today is our fellow graduation ceremony at 1 o'clock. So that's a very big day here. I'm sad, though, because we're going to lose a lot of great people. But we're gaining 2 great people, too. That's the way it goes. Okay, I guess we'll just get going. Why not? Okay. Ooh, that's an interesting noise. Okay, why don't we go to, let's go to Sergey. Good morning, Sergey. How are you?
Good morning, Dr. Press. I'm good. How are you?
I'm well, thanks. Okay, so this is a 2-week-old who I'm going to show you the tracing in a moment, but on post-op day number 4, following tetralogy repair, had a sudden rise in his heart rate, and I'd like to thank Dr. Lawalia, who was kind enough to send me these tracings to brighten my morning or evening. Oh, actually, it had to have been the evening. It always is the evening. So this is the patient's baseline surface electrocardiogram on post-op day 0 when they came back from the operating room. And let me just show you the tracing here. So this is the tachycardia that Dr. Lawalia sent to me.
Mm-hmm.
So what do you think is going on here?
So the rate is, I would say, about 180.
Mm-hmm.
It's looks like a narrow complex tachycardia.
Well, why do you say that? It's just a narrow. What's the definition of a narrow QRS tachycardia or narrow QRS, I should say?
QRS interval less than 0.12.
No, it should be less than like 50 milliseconds.
50 milliseconds.
So
then it's a wide complex.
Right.
So maybe a VTAC or?
Well, let me just show you. This is the patient's ECG before. So let's look at this tracing. Is the patient in sinus rhythm in this tracing?
Trying to see the P waves for each QRS. I don't see P waves in. Oh, they're hiding there. Okay. So then it is a sinus rhythm.
Right. So it's sinus because there's a P before every QRS, and because the P wave seems to be probably upright in 1 and F. Okay.
Mm-hmm.
So so it is sinus. Okay. Now,
Okay.
and is this a narrow or a wide QRS?
Narrow.
Again, the QRS is pretty wide, don't you think? I mean, it's definitely more than a box, right?
Oh, yes. And,
This is the right bundle, right?
yes.
It's
V1
right
is
bundle.
wide. Yep.
Right. So as an RSR prime in V1, so that would be consistent with right bundle branch block. So what I'm trying to get at is it's very important to look at the original ECG if the patient were in sinus rhythm in order to understand what is the patient's new normal. And when a patient has had tetralogy surgery, it's not uncommon that the that the QRS is wide because the patient had to have resection of muscle bundles. And oftentimes the surgeon will injure the right bundle in doing that or doing a ventriculotomy. So this is the patient's new normal. And in tachycardia, I think you would agree that the morphology, just going back and forth, is largely the same. It's a little wider, but it's basically the axis is the same
Mm-hmm.
and morphology is the same. That's important. So let's get back to this tracing. So we're at a rate of 180. I agree with you on that statement. Are we in sinus rhythm?
I guess if the P waves are again kind of hiding in,
Well,
I
in
can't
this
see them clearly.
I think the P waves are quite obviously present, but in this
Okay.
tracing, we don't see any.
Yes. So not a sinus rhythm.
Not sinus rhythm. And if we look in lead 3 here, I think we would notice that there is a new deflection that can be seen following the QRS that was not there before. So
That's a retrograde.
Could be. So if you have a wide QRS tachycardia with what appears to be possibly 1-to-1, so then Dr. Lualio did an A-wire tracing in which she attached V1 to the A-wire. So what do we think is going on there? What are we demonstrating here? What did she demonstrate for us?
V1 A-wire tracing.
So what we're seeing, right, is a sharp deflection that is related to the fact that the electrical lead is attached to the wire that's been attached to the right atrium. And so we're seeing basically that almost simultaneous with the surface ECG, or the QRS, we're seeing a P wave or an A wave. And so this means that there's 1-to-1 conduction. And so when somebody has a wide QRS tachycardia and they have 1-to-1 conduction, the differential diagnosis would be either VT or it could be jet. But the only way you could tell, remember that jet is also sometimes referred to as His bundle tachycardia, meaning that the impulse begins at the level of the His, and therefore the QRS in jet should look exactly like sinus. And we've already established that the sinus and the sinus rhythm and the tachycardia rate rhythm, the QRS looks the same. So this would be a junctional ectopic tachycardia. And so Dr. Lawalia made that diagnosis, and now I'm going to ask Dr. Grace Kong, how would you treat this?
The patient has atrial wires still, it sounds like, so we could override PSIC.
It would be impossible to have the tracing that we're looking at here without that. But I will tell you that Dr. Lawalia told me that this, actually now it's all coming into focus again. This was fairly late at night, and she told me that the wire, that the sign out was that the wires did not capture.
Okay.
Just as an FYI. They clearly can record though, right? Because we have a nice atrial electrogram.
Mm-hmm. The patient, you could do cooling and you could do prog.
Right. So you cool the patient. At what temperature would you want to get the patient to?
Is it like 30? Close to 30? I'm not sure, Dr. Pass.
Okay, so 30 would be very dangerous because at that temperature, that low of a temperature, it had ventricular fibrillation. In fact, that's one of the ways that people are put onto bypass or circ arrest is that bypass, they freeze the patient down. In fact, some operating rooms are designed to have very low temperatures for just that purpose. So if you go too low, it's bad. So 30 degrees Celsius would be way too low.
Okay.
So you're shooting for about 34 or 35 degrees centigrade.
Oh, okay.
Okay, and how would you do that?
You could do cooling blankets.
Right, that would be the most typical way. Any other precautions you would take if you were cooling a patient? Could you cool a patient who is, let's say this patient was extubated on post-op day 1 and we're now post-op day 4. Could you cool this patient?
Oh, no, you would have to intubate.
Why is that?
Your end organ perfusion would probably decrease and you would want to sedate and paralyze the patient, or not necessarily paralyze, I guess, but sedate at least.
Well, you're right, but the reason's a little off. The cooling is very unpleasant. It's
right.
So,
that too.
And it also causes shivering, which is a very bad use of cardiac output. And so presumably the reason you're treating this rhythm is because you're in low cardiac output or you're fearful that you're in low cardiac output. And so you would not cool somebody to 35 or 34 degrees unless they were intubated and you were able to heavily sedate or even sedate and paralyze the patient. But this patient was actually still intubated. So you could have cooled the patient and then added procainamide. And how much procainamide would you give Grace Kong?
I don't know.
So the dose is usually we start with 10 per kilo.
Okay.
But, in a paper written by Lizzie DeWitt at Boston Children's, she described giving smaller doses frequently, like 5 per kilo or 2 per kilo, and repeating it until you had effect. What is the biggest side effect when you're giving procainamide to a child in the ICU or anywhere really? What's the most common thing that happens?
You can drop your blood pressure.
That's right, because procainamide, although really not a negative inotrope of significance, it does cause vasodilation. So it's not uncommon that a patient needs volume when you're giving procainamide. Although again, the team in Boston says that if you give this small enough doses as boluses, you will not typically need to resuscitate with fluid, but it's very common that when you give a bolus of proc, you'll do that. So you typically would give an equivalent of about 10 per kilo over a period of time, and then you would start a drip, usually at 20, and oftentimes that will work. And in fact, that is the most effective approach to the management of jet that has been described in the literature. What is an alternative approach that you could use?
Could you use amiodarone?
Right, you could use amiodarone. amiodarone is very commonly used for the treatment of JET, although surprisingly, with very limited evidence of its efficacy, or not great efficacy, and a very high profile risk of serious complications. So this happens to be a very young baby. I think you know who this is, and amiodarone can cause cardiovascular collapse when it's given IV. Now, you at the outset of your answer had mentioned the possibility of overdrive pacing this rhythm. So somebody told Neha that these wires don't work. So how would you, so the first thing you would do, of course, is you plug them into the pacemaker and turn it on and see if you can capture. And let's say, for the sake of discussion, that you cannot capture. What would your next, and you increased the output maximally.
Okay.
So you're at like 20 or 25 milliamperes and you're still not capturing.
Mm-hmm.
So what would your next move be to try and determine if the lead is adequate to pace?
Mm-hmm. I could change the sensitivity. I
No,
could.
no, sensitivity has to do with sensing. You're trying to pace.
Right.
Okay, so you've increased the output maximally, not capturing. Anything else you can do?
Absolutely not capturing. I could switch the polarity.
Right, you could switch the polarity because, remember that when you're pacing, there's a cathode and an anode, and it might be that one of the two ports is not touching the myocardium well, but perhaps when reversed, it would work. Unfortunately, oftentimes neither is touching at the same time, but that would be the first thing to do. So you've now reversed the polarity and you are not able to capture the atrium still. Any other moves you could make?
You still have ventricular wires, Dr. Pest?
You do have ventricular wires. They're there, and by report, they're working.
I know for our kid that went to rehab, Dr. Pest, you put one ventricular wire in and one atrial wire to use the ventricular as a ground.
So you could use the ventricular wire as a ground and try each of the atrial wires using a ventricular wire as a ground. Now, you have to be careful when you do that because you might capture the ventricle. But sometimes you might find, though, that at a lower output, you're able to capture the A without capturing the V. So you have to run the electrocardiogram as you're doing that. So you could try that. And the only other option is to get a higher output device. Some of the older bedside pacemakers, the ventricular port will pace with 5 milliamperes more than the atrial port. So you could try placing the atrial wire into the ventricular wire and programming it VVI, which would really be AAI. Try that. But if all of those failed, there's one other thing you could do, which is you could put a new ground lead in, right? So you take
on the skin.
In the ICU, they have wires, pacing wires, and you can basically take an epicardial temporary pacing wire and put it right into the skin. Typically, this is done near the sternotomy in the chest, and then you can use that new skin lead as a ground and try that with each of the atrial wires to see if that works. That would be the options you have. And what is the so the patient's going at 180, and presumably you would have to pace faster, right, in order to capture the atrium. So let's say you do capture and you're pacing at 185. Is that so now you're in you have atrial ventricular what's the word I'm looking, synchrony. So is that guaranteed to be better than JET?
Usually is. I don't think it's guaranteed because it's so fast.
That's right. So that's a very good answer. So basically, that's exactly right. You don't know. Sometimes When someone is paced in the atrium at 185, the hemodynamics may be substantially better, but sometimes they might not be. And so you really have to, it's a little bit of an experiment. You have to go to the bedside, pace the atrium at a faster rate. Of course, you're doing all the other stuff we talked about, either cooling with procainamide or IV amiodarone, but you're doing that in order to see if you can if you have AV synchrony by pacing the A, if the hemodynamics improve. Sometimes the hemodynamics will be substantially improved, even when you're pacing at 185 or 190. Other times there'll be no benefit. It might even be worse. So you have to really, every single patient is on a patient-by-patient basis. So you would go to the bedside, you would increase the pacing rate, and you would watch. You would look at the blood pressure, at the intracardiac pressures, like the right atrial pressure, is it falling? These would be good signs that this is beneficial to the patient. In this particular case, the ICU attending was not interested in pacing at 185, only wanted to give amiodarone. And amiodarone was given, and about an hour or two later, the tachycardia slowed and went back into sinus rhythm. So, and then I think about 12 hours later, again had jet and had to have another bolus of amiodarone, but is now in sinus rhythm. Okay, let's move on. So why don't we go to, let's ask Perno, what's going on here? This is a 6-month-old, also tetralogy repair, who has an irregular heart rate.
Yeah, I'm looking through.
Thank you.
So I do see upright P wave in 1, 2 AVF.
I agree with the statement.
Yeah, so it is sinus. I am.
And what's the rate, Verna?
Sorry, yes.
It's a little hard to tell, but I'll be honest.
Yeah.
I actually gave you a crappy background. So let's assume for the sake of discussion that the rate is 150. Okay.
Okay, and this is a 6.
It's actually a little slower than that, but about 130 actually.
Okay, 6-month-old. And then the PR interval, again, it's very difficult to say exactly, but
Not that difficult.
1, 2, 3, 4, 5, about 200 milliseconds.
Is it fixed? For example, is this PR interval the same as this PR interval?
No, it's prolonging.
Right.
It's prolonging, and then
What
it does
happens
not
here?
conduct at one point.
There's a P wave that's not
P
conducted.
wave conducted, and then we have another complex where the P wave is conducted, and then it still again continues to prolong and then drop. So it's Wenckebach.
Right. So this is type 1, Mobitz 1 second-degree heart block, otherwise referred to as Wenckebach. Notice also the grouped beating, right? So you oftentimes people who have, if you just look at a tracing quickly and you see this type of group beating, you should in your mind think that is this possibly Wenckebach. And in fact it is. What you're seeing here is a PR is prolonging until you drop 1. Now, let's say that this patient is in your office and is, say, 6 weeks following repair of tetralogy, and you see this in the office. How would you manage or evaluate this?
You would do a Holter to
Right? Do
see
Holter.
how.
What are you looking for on the Holter?
How often is it happening, and also if it's progressing to like a higher degree heart block.
That's right. So when someone has Wenckebach, where is this occurring usually in the His-Purkinje system, in the AV node His-Purkinje system? Is it at the level of the AV node, or is it typically below the level of the AV node at the His-Purkinje level?
It's at the level of AV node.
Right. So generally, Wenckebach is usually at the level of the AV node. You can have His-Purkinje Wenckebach, but it's very uncommon. So generally, the higher the level of block, the less worrisome. So we would be generally less worried about this. Patient is asymptomatic. And so I agree with you. You would do some form of monitoring, whether it's a Holter, a Barty, a Zio, to see if this is the highest grade block that the patient has. And if this is the worst that you see, and if the patient is asymptomatic, then you would not necessarily need to put a pacemaker in somebody like this, but you would certainly monitor someone like this, because this is distinctly abnormal following open heart surgery. And we've talked in the past that if you develop a high-grade second-degree or third-degree block following open heart surgery, that would be considered an indication for a pacemaker, but this would not in an asymptomatic child. Okay.
Okay.
Let's move on here. I think we have David here. David Barris, good morning. How are you?
Good morning. I'm well, thank you.
We're looking forward to your arrival.
Let's look at this here.
This is a 12-year-old. This was just seen on a Holter. And what do you think this is?
So first looking at the rate here.
It's a little hard to tell because the background is so terrible.
Is it about
Yeah,
60 feet per minute?
let's assume that it's 60. I'm sorry, some of these tracings have bad backgrounds, so I apologize.
And then in terms of the rhythm, I mean, I'm just seeing channel 1, channel 2, channel 3, so I'm not sure what that corresponds to on the typical ECG leads, but regardless, I am seeing upright P waves before at least the first 2 complexes, but then disappearing at the 3rd complex and the 4th complex. And then perhaps I'm seeing P waves after the QRS complex. And then interestingly, I'm seeing a narrow complex for the first, those first complexes, and then it becomes wide complex. Almost like a double, like 2 peaks on some of those complexes at least. And then looking at the end of the tracing, it looks like it becomes narrow again with the P wave beforehand.
So I agree. We have narrow QRSs on the left and narrow on the right and wide in the middle. So what do you think those wide beats are?
So they can be, PVCs, like premature ventricular complexes. I mean, I think that would be my best assessment.
Yes, I think you're right. And so what this is sinus rhythm with an accelerated ventricular rhythm. And it's, if you notice, the R to R interval on these wider complex QRSs is slightly shorter than these, although it speeds up here. And so this is just an example of idioventricular rhythm when a patient is asleep. So they're in sinus rhythm with a P and a QRS, a narrow QRS. And then you see there's a P wave here, but this is not conducting because the QRS is too close to the P wave. The human being AV node in his system can't conduct that rapidly unless there's an accessory pathway. But what this really is just accelerated ventricular rhythm. And this is a nice demonstration of the fact that whatever is fastest in the heart usually wins. And so for some reason, the patient has a focus somewhere in the ventricle that is beating slightly faster than the sinus rate, and therefore the patient is in this idioventricular rhythm. And then as the sinus rate accelerates, this is extinguished and the patient is back in sinus rhythm again. And so typically, this is not an abnormal finding per se on a Holter, particularly when somebody is sleeping. And we would, usually you would just make sure that how much ventricular ectopy a patient has and whether there's any fast ventricular ectopy. But this would generally be viewed as a benign finding that does not require intervention. Although you might want to see at least 1 or 2 Holters to make sure that this is as bad as it gets, as it were. If it is, then that's not terribly worrisome at all. Okay. All right. I see I'm going to ask Dr. Ellis Rochelson, since he's about to go to Texas Children's Hospital to be an electrophysiology fellow, this question. Ellis, this is a patient who is in sinus rhythm and then something happens. And I'm asking the question, where is the accessory pathway located?
Okay, so
Can you tell?
I can't, oh, I see 1 and V6 now are labeled. So in this rhythm, when the patient goes into tachycardia, they develop a left bundle branch block pattern, evidenced by the wide prominent R waves in V6 in lead 1. And you can compare in the middle of the screen, there's tachycardia, as well as on the right side of the screen. And I think the tachycardia is slower during the bundle branch block. So that would suggest when you have left bundle branch block during orthodromic reentry tachycardia, it suggests an ipsilateral pathway. So it's like the left-sided accessory pathway.
That's right. So let's just break that down, since some of the people in the audience may not have gotten all of that technical mumbo jumbo. So if we only saw these beats, we would have to assume, as the computer is, that this is VTach, because it's a wide QRS tachycardia. It's quite clear that the morphology of the QRS is very different than the morphology of the sinus beats that are on the side here. But the clue here is that on the right side, we start to see a narrow QRS tachycardia with a morphology that is extremely similar to the sinus rhythm. And so it is possible that this is VT that turns into some sort of narrow QRS tachycardia, but the more likely thing is that the two things are the same. Now, these beats here are slightly wider than these beats here, and or actually substantially wider, but they also are slightly slower, as Ellis said. If you measure the R to R interval here, they are ever so much longer than the R to R interval here, but they're very similar. The rate is about 300 beats per minute, but over here, I think it's really more like 270 or 280. And so basically what's happening here is, so the likelihood is that you're starting tachycardia. There is bundle branch aberration because the bundle branches often take a little time to warm up, as it were, in tachycardia. And after about 20 beats, we narrow as the His-Purkinje system starts to normalize. Now, when a patient has, and this is just a random event, everybody's bundle has a certain ability to go at a certain rate. And in this particular individual, it took a couple of beats before the QRS narrowed. Now, this is a gift, however, diagnostically, because we see that the morphology of this bundle is a left bundle. And that means that there is a left bundle branch block, meaning the left bundle is conducting a little slower than average. And so when you are going down the left bundle, when the left bundle is conducting more slowly, and you have a left-sided accessory pathway, you would expect that the R to R interval would get longer because it takes longer to go down the bundle. Remember, you have to go down the AV node, down the His-Purkinje system, in this case, the left bundle, to the ventricle, and then back up to the accessory pathway and the atrium. And if the left bundle, if the bundle on the side of the accessory pathway is affected in this manner, causing slowing through the left bundle, then the pathway on the same side will see the impulse later, because it takes longer to go from the A to the V, meaning that the tachycardia will be a little slower when the patient has a left bundle. And so if the morphology of the bundle is such and the R to R interval is longer, we can say that the accessory pathway is on the left or the right side. Now you notice that in sinus rhythm, the patient is not pre-excited, so we can't tell from the surface ECG where the accessory pathway is. However, if you have a bundle branch block and you have a lengthening in the R to R interval, then you can say that the accessory pathway is located on the ipsilateral side of the morphology of the bundle. In this case, it's a left bundle, and because the R to R interval lengthened in the presence of a left bundle, we would surmise that this is a left-sided concealed accessory pathway. So this is a nice demonstration of that, of how you can tell if you're lucky enough to have a 12 lead or a 6 lead when the patient has a bundle. You can tell whether it's a right. So if you had a right bundle with a lengthening in the R to R interval, then you could make the observation that this is a right-sided accessory pathway. But in this particular example that I've given you in lead 1 and V6, we have very big upright QRSs, as Alice said. And so this is a left bundle tachycardia that narrows. And so again, just looking at the wide beats alone, there'd be no way to know that this is aberration. It's only when you see the beats to the right that narrow that you know that this is likely the same rhythm going from an aberrated complex to a narrow complex. If you only saw the wide beats, you would have to say this is VT until proven otherwise. Although I think you would say that there clearly seems to be a retrograde P wave following every QRS that you can see here, but that could also be present in VT as well, right? Patients with young, healthy patients have normal retrograde AV nodal conduction. And so you can be in VT and have one-to-one VA conduction in a small patient as well. So all we can say is that it's a wide complex, but then it narrows. So this is a very nice, elegant way to predict where the accessory pathway is. And sometimes we get lucky and we can do this. And years ago, Jared LaCourte, after he finished his fellowship, called me and sent me a strip like this and told me that he thought the patient had a left-sided concealed pathway. And that was when I knew that EP conference was a worthwhile activity, because he made that diagnosis. Okay, let's move on. Good job, Alice. Okay, let me see who we got here on the call. Uzo. Good morning, Uzo. Are you still there, Uzo? Uzo is out of commission. Let's move on to Simone Javeri in her very last EP conference of all time.
Good morning, Dr. Fass.
Good morning, Simone Javeri. Never to be back in EP conference. How relieved she is. Okay, this is an 18-year-old who came into the emergency room 2 nights after a night of heavy drinking, which I do not condone, and is feeling palpitations. So what's going on here? Look how old this ECG is, from 2006.
So this patient
Now a 30-year-old, 32-year-old, but at that time, 18.
it looks like he has variable RR intervals, and then the P wave morphology is not. It looks like an irregular rhythm with P waves that are not easily discernible, so probably atrial fibrillation.
That's right.
variable conduction.
That's right. This is AFib. Now, anything about the history that would have led you to this diagnosis? Is there any relationship that you're aware of for heavy drinking and this arrhythmia of atrial fibrillation?
Not exactly. No, I know that alcohol might be able to cause it, but I'm not sure.
So alcohol actually is a very pro-arrhythmic agent. And in fact, heavy drinking is associated with the development of atrial fibrillation. In fact, there used to be an old-fashioned term called holiday heart. And emergency rooms throughout the United States and world see a large number of people come in after midnight with atrial fibrillation after a heavy night of drinking. Alcohol in general is very arrhythmogenic. It's actually one of the substances, for example, if you have Brugada syndrome, you're not supposed to drink alcohol other than very sparingly because it also can be arrhythmogenic in that condition. But for all human beings, alcohol is actually arrhythmogenic. Okay, so it's 2:30 in the morning, and this patient is in atrial fibrillation and has been feeling this for 2 nights. So what are you going to do, Simone? You're on call for the first time at Cohen Children's Hospital. Dr. Schlein, the chairman of Pediatrics, is doing a rare stint in the ICU that evening, and you want to impress him. So what is the plan you're going to tell your chairman about how you would like to manage this 18-year-old truant who has drugged too much?
I mean, if he's had already 2 days of symptoms, I would get a quick echo, just look at his function, make sure his anatomy is normal.
Anything else you're looking at on the echo?
On the transthoracic, I would look for an intracardiac thrombus, but it might be not. It's not the highest sensitivity to detect one.
That's true. So if you saw one, it would be very helpful, but if you don't see one, it is meaningless because of exactly what you just said, yes?
Yeah. And I guess this is low atrial fibrillation, right? This is his first episode.
So is there anything you want to do right now? It's 2 in the morning. Your fellow on call has done an echo, you've looked at the images. You don't see a large thrombus. The function is fine. The heart rate, as you see, is not terribly fast. So what would you like to do? Dr. Schlein is very angry because he's been up because of this kid. And he's asking the fellow in the ICU, what does cardiology want to do?
So you could do heparin, get a TE the next day, and then cardio work.
That would be the most common thing, and you're giving heparin to try and prevent the development of a thrombus on the assumption that maybe there isn't one yet.
Mm-hmm.
So yes, so you would give heparin. You don't have to rate control this patient, right? Because they're already fairly slow. So you don't need to put them on any kind of AV nodal blocking agent. So yeah, that would be the most common thing, right? Is to start them on heparin and say in the morning, we will do a TE. So make the patient NPO for general anesthetic and do a TE, and then you could cardivert the patient. Anything else you could do? Let's say the patient has a history of esophageal atresia and has had lots of esophageal issues, has to be bougied every 6 weeks for the last 4 years because of stenoses in his esophagus.
I would not want to do a TE.
That's correct, you would not. So
we could do a CT scan.
In this very strange world.
Yeah, we could do a CT scan to look for thrombi.
That is an unproven approach, but I can't speak to how good that is. It seems like it would not be very good, but I might be wrong.
I mean, apart from a TEE,
you can't do a TE because he has esophageal strictures.
Yeah.
So what you would probably do is what we used to do in the old days, really almost before my career started, which is you could just put this patient on 6 weeks of anticoagulation with either a NOAC or warfarin, and then bring the patient back at 6 weeks and cardiovert. Given that the patient's heart rate is not very fast, they're not really at risk for development of a cardiomyopathy. And the old-fashioned traditional approach would be to just give somebody oral anticoagulant for 6 to 8 weeks, and then bring them back. And you can cardiovert a patient without even doing a TE, because the likelihood of it being successful at dissolving a thrombus is extremely high, actually. And it's a very effective, safe approach. The reason that we don't do it is because we like instant gratification in the present era, and we like to convert everybody immediately. But this patient could certainly be managed with just a therapeutic anticoagulant for 6 weeks and then cardiovert at that point. That's a very reasonable, old-fashioned approach, and that would avoid the need for a TE. Christina Fink is asking, would you have them wear a Holter in order to make sure that they're not having rapid ventricular response? Yes, I certainly would do that. We don't really know if a patient's lying on a bed, they're going to conduct a lot slower than if they're exercising and active. So you would certainly want to keep eye on, see what the R to R intervals are, and if the patient is getting faster intermittently. But they're not at risk, for example, for sudden death or anything of that nature, because there's no accessory pathway. So the worst that'll happen is they'll start conducting it like 180 or something, which is not good, but is generally not life-threatening. So yeah, you could just orally anticoagulate. And because you have to remember that the TE, when you're doing a TE to rule out a thrombus, it is not 100% effective at identifying thrombi, right? I think something like 1 or 2% of people can still have a thrombus that cannot be identified on TE. So it is not perfect to do a TE in cardiovert. In fact, some people would say that anticoagulating for 6 to 8 weeks is actually safer. But I think most of us in the present era would not do that. They would just do a TE and cardiovert. So if you're on call next week at Cone Children's Hospital, don't recommend 6 weeks of oral anticoagulation. We want the attendings there to feel you're providing modern medicine there. So Simone,
doesn't have esophageal strictures. So
and we have to hope that your first patient that you want to do a TE in does not have esophageal strictures. That would really be a bummer. So I think with that, we're going to stop right now. I want to thank you all for joining, and I want to congratulate Dr. Javeri on finishing up EP and EP conference. I remember her at EP conference many years ago. You're all done, but remember, the learning doesn't end here. So
thank you so much, Dr.
All right, everybody have a wonderful day, and I will see you soon. Be well. Take care. Bye-bye.
Thank you.